got into trouble. Okay. Yeah, you guys know what I mean. So, this is inspired by a case that I actually saw fairly recently, towards I think it was November. So, primarily osteomyelitis, or how I call it osteo, is a disease of the bone or the bone marrow that starts off almost exclusively as an infection. If untreated, it goes into sepsis. Patients go into sepsis. So it's classified according to source and according to the time frame when things develop. So according to sources, hematogenious seeding, mainly for the children. It's hematogenious seeding for the children. Because there's a lot of endosteal blood supply, the growth plate is evolving, and just blood flow is high. That's why when they get bacteremic, it goes directly to the bone, especially in the long bones. Sometimes you see osteo after soft tissue infection or overlying soft tissue infection, or from a contiguous foci, or sometimes in trauma. In terms of duration of symptoms, usually things are acute, meaning less than 2 weeks. Sometimes you find subacute and chronic infections. Chronic infections usually present more in the developing nation because of poor access to care. Most of the time we see them in forms of acute hematogenious osteomyelitis. So a picture of the bone, this is where it's highly vascular. So if you can imagine, patients become bacteremic, and why do kids become bacteremic? Your best guess is my best guess. In the adult world, like I always say whenever I'm on the peds floor, when people brush their teeth, they get bacteremic. Kids, sometimes they probably scratch themselves, bacteria get into the skin and they become bacteremic. And by virtue of the fact that there's a lot of blood supply to the bones and the developing tissues, bacteria tend to land there. What is its pathogenesis? Like as I mentioned, the bacteria goes from the blood to the bone, where it's highly vascular. The problem is the loops of cartilage here are sluggish. So once it hits the bone, the bacteria isn't cleared very well, so it sort of sets up shop and becomes an initial site of infection. So after that, you develop a blocked blood supply and then the bone necrosis. And then when you get the bone necrosis, the area around it reacts, pus forms, it goes out of the periosteal space. And then in chronic osteomyelitis, you form new bone, which we call the involucrum. The sequestrum is the dead bone, the necrotic bone, which, as I always say, you can never water a dead plant. So dead things technically have to go, because no amount of antibiotics that you give to them will heal it, because you cannot water a dead plant. So, moving on, these are my friends. People laugh at me when I say they're my friends, but they really are, because I'm happy when there's something that we isolate, because it means that there's something that I can tailor therapy to. When there's nothing isolated, I sometimes want to bang my head on the wall, because your best guess is my best guess, and we can all be, I can be wrong with whatever treatment I give. But my friends, usually for kids, the prime suspect is still Staph aureus in about 70 to 90% of the scenario. Again, the difference lies is if it's MRSA or MSSA, and later I'll go into that. There are also cases of Group A strep, strep pneumo, Group B strep, and then coag-negative staph. But usually infections of the bone with coag-negative staphylococcus are most commonly seen in implants when you have prosthetic material, because it tends to stick to that, and subacute kind of infection, something brewing. For the gram-negative bacteria, Klebsiella kienii is a prime suspect, especially in kids. It was not until the advent of PCR that it actually came into light. Before PCR, they would get culture negative infections like endocarditis, culture negative osteomyelitis, even if they biopsy the bone. And in the advent of PCR, when things are being identified at the molecular level, they noted that this particular gram-negative bacteria has a high incidence in children less than 5 years old. So, other things not common in the pediatric population are fungi, endemic fungi, histomycosis, blastomycosis, and cryptococcus, and then also candida. But those are not for kids typically. We can probably see them in patients who are immunosuppressed, but not in your regular healthy, seemingly healthy pediatric population. So there's a very slight increase. Well, if you compare, there's a slight increase of MRSA versus MSSA in the isolates of Staphylococcus. Probably my view is skewed that I'm seeing more MRSA, but at least in GRMC, I've seen a couple, kids with more MRSA than MSSA. Luckily, and this I'll talk about in treatment, we only have less than 25% Clinder resistance for both the antibiograms from GRMC and GMH. So I actually peeked through both. So I know that there's only less than 25% Clinder resistance, and I'll mention that later in treatment. So in terms of infection with MRSA, there's a higher complication rate, meaning presence of more myositis, more bone abscess, more pathologic fractures, DVTs, and disseminated disease. And some people were saying, is it because we are not empirically giving proper coverage to that particular kind of Staph aureus, that's why we get more complications. But an actual study determined that it is actually, the complication rate is comparable, be it giving proper empiric therapy or not. What is different is, with MRSA, medical management may not be completely enough. So you have to do more surgical drainage because it's a more aggressive bacteria in a way. It's a more aggressive kind of Staphylococcus aureus, stickier, and of course more resistant. So in terms of community-acquired MRSA, which we do have a lot of, even in kids, there is an increased inflammatory response, increased need for surgical management, and more multifocal disease, meaning you have things like septic emboli to the lung, to the brain. You see that more often with MRSA. Kingiella kingiae is, again, a gram-negative bacteria that's fastidious. It's very hard to grow. So when we get culture-negative infections, I tend to call the lab and say, hold everything for 21 days, which is kind of crazy. But believe you me, we've grown things in as late as about 20 days, which actually helps tailor therapy. So in terms of manifestations, bone pain is hallmark. It's a kind of bone pain that's constant and progressive, and in children it limits them from moving that particularly affected joint. You can imagine the reason why usually they develop a limp because again the bacteria sets up shop in the long bones, and that's what gets affected initially, and then they develop that limp because it becomes really, really painful. The classic inflammatory signs only happen when the infection has progressed through the cortex to the subperiosteal space. So it's sometimes rather late, like mid-game, not early on. So sometimes you won't see erythema, you'll just see maybe some swelling, but the pain is remarkable. So in terms of identifying or suspecting when a child has acute hematogenous osteo, you will note that there's a lot of bone pain and fever. And this is localized bone pain, like you palpate the area where the child is complaining of a limp, and then they'll be hesitant for you to touch it. Related to osteo is septic arthritis. So In patients who actually have a lack of point tenderness, but significantly are not able to move a joint, you think about not just osteo, but also septic arthritis. If you go back to the picture of the long bone, the bacteria sets up shop in the metaphysis of the bone, but you will see that the metaphysis is near the epiphysis, which connects to the other bone. And sometimes with the blood supply that the kids have, that actually becomes a portal for where the bacteria exits and then gets to another joint. So you may have both osteo and septic arthritis, but the septic arthritis may present earlier because of exaggerated joint immobility, not just the joint itself. Here. Moving on, there are complications of AHO. Again, this is the image that I showed where they set up shop. They have subperiosteal abscesses, and this is more of a chronic form, the dead bone, and then the formation of new bone. And all of those would have to go away. I'll discuss that later. The other complication you have is myositis, and that is inflammation of the muscles surrounding the initial site of infection. You can also have septic emboli to the lung, and then also septic emboli to the brain. Although in kids, we usually see hematology seeding more to the bone rather than through here, to the brain and to the lungs. This usually happens when your bacteremia also creates endocarditis, because it's easier for the particles to fling off and go to different parts of the body, which you can also have splenic infarcts or splenic abscesses as part of its complication. So what kind of diagnostic modalities do we have? This is fairly basic. Leukocytosis, elevated ESR, but you will see that there's more elevation in the CRP, and it is most sensitive. I will share the case that I had towards the end of the presentation, but we see more response from the CRP in terms of predicting if the patient is clinically getting better than the ESR. So in terms of imaging, plain radiographs may be beneficial for patients who've had a longer period of symptomatology. This is because the changes that you see on X-ray, like osteopenia, formation of patterns like osteolysis, which is destruction of the bone, they tend to happen about 2 to 3 weeks after symptoms. So its utility mainly is in patients with prolonged symptoms, or if you want to exclude a fracture. The next diagnostic modality that they talk about is skeletal scintigraphy, which we in the adult world don't really use because everything will light up. That's what we say. Like if you do skeletal scintigraphy in the adult, everything will light up. So just don't do it. It is used for poorly localizing symptoms for kids who cannot really say where it's hurting or what's hurting, and for areas that you suspect multifocal lesions. The problem is it uses ionizing radiation, so it's not for the neonates, and it's difficulty to distinguish infarcts from sickle cell, fractures, and neoplasms, because all of these things tend to take up the tracer, and it will light up. And then it will confuse you. So this is osteo of the great toe. There. Different patterns for different stages of the uptake of the tracer. So it basically functions like your tagged white cell scan, and findings should be taken with a grain of salt. The next modality we move on to is CT scanning. It is a good picture because it takes the anatomic location and the state of the infection. So this is a site of osteo where it's hypo-attenuated, and then you can see this area of possibly new bone formation. It detects findings of chronic osteo, which is the sequestrum, which is the dead bone, intraosseous gas, and then it can also define abscesses, subperiosteal abscesses, which are all important for treatment. However, in children, it exposes them to radiation, so that's the downside. MRI identifies, like CT, identifies the anatomy really well, and it helps the surgeon localize where they're gonna puncture holes or open up for surgery. The problem is the cost and the availability and the need for sedation. So I guess if your patient can sort of sit still for about 30 to 45 minutes, which I can imagine can happen in adolescents, but not really the younger ones. You probably are better off with doing an MRI. In acute osteomyelitis, the first finding you'll see is bone marrow edema. And we always say that if you see bone marrow edema, it will be osteomyelitis until proven otherwise in the correct clinical setting. However, even if you have all of these diagnostic modalities in place, the gold standard for treating it, you will need bone culture. The reason is sometimes the patients, you are lucky if you get them into a point where they're febrile, they're having shaking chills, and you isolate the bacteria. But what if you get them at the stage where they're not really chilly, you cannot get anything in their blood? You would have to actually go into the bone, take a piece of it, and send it for culture. Because you always want antimicrobial guidance, and especially on the island, where I'm surprised to see a lot of resistance even in kids. You'd rather them go in there, get a piece of bone, and send it off for culture. Because again, the treatment is between 4 to 6 weeks. And I always say, if I make a mess in a kid, that's really bad. So, not that if I make a mess in the adult, it's not bad, but you guys get what I mean, right? It's traumatic. So, the treatment mainly is two-pronged. Antibiotics and surgery. I found this really nice slide, which actually I should share when I give a talk to the surgeons. Antibiotics are only effective before pus forms. Antibiotics will not sterilize dead tissue. Antibiotics prevent the formation of pus once it's removed, and antibiotics are needed after surgery. So pus removal restores the periosteum of the bone, and it restores blood flow. So what this all says is, well and good if you don't have pus. But if you have pus, the antibiotics are not going to work because they're too acidic. The antibiotics are not going to get in there. So you need to take out the pus. It needs to be drained. In terms of antibiotics, what antibiotics have shown efficacy in bone and joint infection? So we have Nafcillin, clindamycin, first-generation cephalosporins, and vancomycin. If community-acquired MRSA is not of a concern, then you can start off with Nafcillin or oxacillin or even cefazolin. The only downside is if you are treating with vancomycin, know that it doesn't cover Quinella. I haven't seen Quinella here, so maybe we're good. Maybe it's just really mostly gram-positives and your regular gram-negative organisms that we need to worry about for now. Again, antibiotics need to be targeted towards the offending organism because again, if you can imagine, it's a 4 to 6 week therapy. And if you sort of make a wrong guess, you need to start all over again. And I pity whenever we need to start all over again because it's a horrendous thing to be on antibiotics. I actually didn't say that, but yes, it is horrendous to be on antibiotics. For MRSA, if community-acquired MRSA is your concern in about 10% of your population, which on the island I would be concerned, the empiric therapy would be vancomycin or Clinda. And again, why I mentioned, if Clinda resistance rates are less than 25%, which is what we have on island, you can actually use clindamycin as empiric therapy. But I think when patients are too sick and get admitted to the hospital, we tend to go with vancomycin. Note that neither one covers the gram-negative Quiniela. So, or any gram-negative in that matter. So sometimes I've seen it done that it's Clinda and ceftriaxone for older kids, or Clinda and Gent or Bank and Gent initially when the patient comes in. Bactrim and doxycycline are successful in MRSA, skin and soft tissue infections, but not proven in osteo. So I wouldn't rely on it for osteomyelitis, and I don't think you guys would use doxycycline in kids less than 8. Right. My hand gets slapped anyway if I say something inappropriate for children, so, because then it's always like, my go-to drug is ceftriaxone, but then there's a pediatric age group where you can't use ceftriaxone, and then there's an age group as well for doxycycline, and those two drugs are my go-to drugs, so I get reminded whenever I can't use them. So antibiotics should be adjusted immediately once your culture data is available. The newer agents are linezolid and daptomycin. However, I tend to not use linezolid for a long period of time because it causes myelosuppression, a lot of neuro tingling, and a lot of dizziness in kids. And also daptomycin. The problem is daptomycin gets degraded by lung surfactants. So if you have a patient who is actually bacteremic and has pneumonia that's attributable to MRSA, you don't want to use daptomycin. So again, if you have an abscess, intraosseous, subperiosteal, or soft tissue, it needs to be drained. It gives you an opportunity to isolate an organism, but most of all, you remove the devitalized bone and you debride the affected tissue, and you are giving the chance to that periosteum to close up again and to reestablish blood flow. In patients who do not respond to antibiotics, consider surgery. Again, standard treatment would be 4 to 6 weeks. If you cannot do surgical drainage, you'd have to do more than 6 weeks. And this is where your lab values, like your CRP and your ESR, as well as your white count, can be followed, because you don't want to keep on imaging a pediatric patient, so much so that the findings will not change in about 2 to 3 weeks' time. There is a time delay. There's a lag between clinical improvement and radiologic improvement. So when do you switch from IV to PO? It's really unclear. There's no established data. But there have been studies back in 2011 and 2009 that say you can probably do about a week of IV and then switch to PO, depending on the clinical condition of the patient. So if some people would put them on IV until after the child becomes afebrile, and if they're bacteremic, you tend to do the 14 days and then you switch them to PO. And then you again get weekly ESR and CRPs. So to wrap up, this is where this talk comes from. There was a 10-year-old girl who came in with fever and lower extremity pain. She was found to have MRSA bacteremia. She was given vancomycin. On the 4th hospital day, she started to have a limp and left leg pain as well as swelling. And then the 5th hospital day, she had left arm pain and swelling. These are her images. The radiograph of the left lower extremity showed fairly normal bone, except that if you look closely, something's elevated, something's wrong there. This is her MRI of the left upper extremity. Here you can actually see that there's a lot of inflammation, myositis almost. And this one doesn't look normal too, that one. This is her left lower extremity MRI, which shows a lot of inflammation here in the long bone T1 and T2, as well as a lot of inflammation around the muscle area. That one. She actually had subperiosteal abscesses and a lot of myositis. She actually got holed into the bone to drain the abscesses, so those are her bone holes. And after that, she actually depressed, became She became afebrile, clinically well. I think after about 48 hours, we've seen clinical improvement that she can at least now move the leg and walk on it. So her vancomycin troughs were unbelievable. They were like between 10 and 30, 10 and 40. Every morning I'd get called, the vanco trough is 40. Then I'd call, oh dear, is it a true trough? It's just between 10 and 40. And after her clinical improvement, what we did was change her to Clinda. He said, you just do Clinda, because after doing an echo, there was no endocarditis anyway. The caveat is you can do Clinda in osteomyelitis if you do not have endocarditis. And the reason you can do Clinda by mouth is that, again, the fact that you achieve high blood levels with Clinda, and it actually gets to the bone very well because of the rich blood supply in the kids. She tolerated the Clinda well. She did 8 weeks of PO clindamycin on top of whatever vancomycin she got. Her CRP normalized, her ESR had still minimal elevation. She still had a limp, but she's very functional in school. So I will probably see her in another 2 weeks. And she's actually doing well. So the repeat scans show residual inflammatory tissue around the left lower extremity, but it would be hard to say if that's just from the prior infection. Without fevers, without leukocytosis, and with normal CRP, we're just letting it be, keeping a close eye on it. So, thank you. Any questions?